And you can hear us okay?
I can.
Okay, great.
Tony, you want to pick us up?
Oh, yeah. For a prompt. Make sure everybody was in.
Go.
Welcome everybody to the June Alphonse Drug Policy Commission meeting. Just as a reminder, if you're a member from the public, please hold your comments until the end. Feel free to drop something in the chat, and we'll make sure we hold some time again for you. Meetings being transcribed. And then if you are not a commission member, please also have your camera on. And with that, I will pass it to Ashley for roll call. Oh, Annalise for roll call.
Hi, everyone. I'm going to do roll call, and then we're going to give Julie Mines a few minutes to talk about Miracles Club. For those of you who don't know, members of the public, we're meeting in person today at the Miracles Club in Portland, which is very exciting, very fun, and I'm getting food for lunch. So sorry you couldn't make it. So I'm going to get us started with roll call. Grace Massey. Caroline Cruz.
Here.
Deb Jones. Here. Eric Davis.
President.
Erica is absent today. Fernando Pena.
I'm here.
Thank you. Thanks, Fernando. Frankie Yubi.
Here.
Jennifer Kearley. Here. Julia Hine.
Here.
Katie Jokinan.
Present.
Kelly Minty. Here. Maris is out. Monta. Foxy. Here. Mike Obiero. I'm just gonna try to bring that. Sharon Dorsey Martin here. Shira. Stacy. Tim Lynch.
Here.
Yeah, he should. Oh,
Yeah.
okay. I'm Stacy. Tony Vesna.
Here.
Vanessa Nordike. Steve Judgment Maiden is out today.
I'm here. I made it.
Oh, you are here. Oh, good. Sorry, Sarah. Senator Reynolds here. Representative Sanchez.
Here.
Ebony Clark.
Here.
Full house today. And we have Cora. Oh, Shira's here too. Shira, I got you.
Good deal. Hi.
So Julia, want to give everybody a little insight to the Miracles Club here. I will say that nice being here. I came here a lot when I was in residential treatment down the street at VOA. And I lived in Oxford out a half mile away in a few years here.
Good job, Tony. So my name is Julia Mines. As we know, Miracles Club came about in about 1993. It's been in several different spots. The first one was up on Killingsworth and Albina. That was the first Miracles Club. And I don't think it was named a Miracles Club at that time. I think it was named something else, but then soon it changed to the Miracles Club. It was started by a few men that they needed a place to gather and do their recovery because they were not welcome into the white recovery centers. So they started their own recovery center for African Americans in recovery, and Miracles has been going and thriving since 1993. We went from Albina and Killingsworth to a little spot down on MLK that had rain coming through the ceilings and electric cords all over the place, to over here on Northeast Mason, just kitty corner from where we are now. They were there for many, many years. And then, with the help of the county and some members, Miracles members, they got together and you now have this standing building they took occupancy in 2012. It was built for Miracles. We have 40 units of apartments up above. The bottom floor is all Miracles. I think the original group that got this together was called the Real Brothers, that morphed into just Men in Recovery. Yeah, we've been around. Miracles was the first club to actually start doing like recovery, mentorship, and those kind of things that actually, all the you have mentor classes. Miracles did the first one. It was called Each One Teach One. And I remember when they went down to Phoenix to learn to be trained on how to train mentors. And so we've been here, we've been holding steady, we dug our heels in, and here we are today. We have, I think, 8 mentors and 3 transitional houses. Along with our apartments upstairs, we also partnered with Central City Concern, 41 units down at Miracle Central, which is on 2nd and Wasp. So, yeah, we're here. We're not going nowhere. Any questions? Anything I left out? Yeah.
Is there anything that you think Miracles has tried to take differently because of the focus on minoritized?
So that again.
Because of the focus on a minoritized population, is there anything you think Miracles tries to do specifically?
Absolutely. We have a CRM training that is specifically for African Americans. We cater to the African American recovery community, but we don't exclude anyone, but that's what our focus is, catering to the African American community, for the simple fact, African Americans in the state of Oregon our numbers are very small, and we're mainly concentrated in Multnomah County. However, the services that we need because of gentrification, our community has been dismantled. It's all over the place. So we try to be the hub for African Americans in recovery. So our motto is bringing the community together, one person at a time. So yeah, we focus on the African American recovery. But nobody is excluded. Great, absolutely.
Okay, well, thanks for hosting, Julia.
You're welcome.
Appreciate it. Thank you.
Absolutely.
For today's agenda, for director updates, we got some membership changes to talk about. I have a proposal to form an ad hoc work group for data, that metric. We'll continue working on the outcomes of that metrics discussion. And then we'll have just committee updates. Lastly, we'll end with the public comments, like pass it over to you.
Sunny. I will try to be very brief because we have a lot to get through. A couple of things that we'll probably talk about more in July, but I want to make sure everybody knows it's happening. We have our biannual report to the legislature due July 1. So what we decided to do since we finished the comprehensive plan at the end of the year is basically our biannual report will be the summary of the comprehensive plan with the updates from the first 2 quarters, and we'll spend next month's meeting talking about giving you your next quarterly update. And then, so it's not new information. We'll be updating the public health statistics that we put into there to prevalence, and disparities and deaths. So we get that to the legislature. And then, the big state agency financial assessment, that getting to the governor, looks like on time at the beginning of July. We're still going back and forth with some of the state agencies to clarify some of the classifications, et cetera. But that is, it's on track. We are gonna get the governor's input before we bring that back to you all in September. So we're hoping we'll be talking in September, we'll be at a point where we have a public report that we can release to folks. So that's pretty exciting to put together. Those are my big announcements. I did want to mention, just a couple of, summer engagement things that are happening for folks who are interested. There's a prevention summit, in Redmond in July, right? Yes, July, that we are, working on with HIDA, our partners at the High Intensity Drug Trafficking Agency. So for folks who are interested, that is still taking registrations. And then we're also going back to Latinos Unidos in August to do a follow-up community engagement. So I'm also opening that up. Like, I'd really like, if any commissioners are interested in attending that with me. I think it was a really good experience last year, and I think it's a start an ongoing relationship where we work on things together with Latino behavioral health providers. So just wanted to throw that out there. Those are my only big ones. I think we have a couple other membership things that we'll talk about in the next section. Any questions?
Can I, give clarification on the
Latinos Unidos,
Uh-huh.
is a Latino behavioral health provider conference that takes place, I think they're up to every year now in Redmond. And last year we did a Spanish language engagement session. Remember, talking through that with Sal? Yes, this is going back, and doing a follow-up again this year. The conference is in Spanish. So last year we brought interpreters with us. Sal has suggested that this year we do the engagement session in English. So we'll see, what happens.
Any other questions? I'll be able to confirm the thing. Okay, so on to membership updates, we have a lot of changes. And the first thing I actually want to do, because Frankie wasn't here during lunch, but Frankie, you're online.
Yes.
Okay, yeah, okay, there you go. So today's your last commission meeting. I believe you served on here for 8 years.
Yep.
You were here when I got here, and I know as a public defender, and personally a person who cares about the issues, that your insight, contributions, and consistency have been much appreciated over the last few years.
Thank you.
And so I just wanted to give you an opportunity to say any parting words, recommendations, mic drops. Anything you want, but thank you so much.
I've really enjoyed being a part of this process for the last 8 years. Part of both the last strategic plan and this one, and I feel really good about the direction that we're going and having a lot more like oomph behind the strategic plan this time around. I feel like we're in a really good spot to actually execute on a lot of things. And so I just encourage people to keep doing it, keep doing what you're doing. We're in a really good spot.
Tony, if I could,
Yep.
Frankie, I just wanted to let you know, as from the prevention committee, you chose to be with us. And you've really brought a unique perspective, especially from the rest of the membership that we had. That was very valued. You helped us look at things from a different lens. That was very important. So I really appreciate the time I got to work with you, and wanna make sure that you realize that from our whole subcommittee, that we really appreciate the time and what we were able to learn from you while we had you with us.
Thanks, Debbie.
And Frankie, I obviously want to say thank you for sticking with us. As you know, there was a very small group of you and Tony and Caroline, Senator Reynolds, when he's in the house, and Kelly, who have stuck with us through this time of change. And I will reach out so we can find some time. We have a really lovely certificate for you. So as you all know, if you serve your 8 years, that's your big prize. Thank you.
Thank you so much.
Yeah, but we wish you could have been here in person to get your plan.
I wanted to be, but you know, when you got 2 attorneys and a kid getting off the bus, somebody's got to stay home.
No, totally understand. But you know, feel free to continue to attend the meetings, participate in the ways that you're able to and make sense to you. And we'd love to see you. And then today is my last meeting as chair of the commission. I don't know how long I've been chair, maybe 6 years.
5.
At least five or six. And we are light years ahead of where we were when I joined the commission and I was chair and I became chair. A lot of that has to do with Representative Sanchez, as well as Senator Reynolds, and all you know, staff, and then all the new members. It's been great to serve as chair. And we, you know, we're fortunate enough to select Kelly as our next chair, but she has some information to share with us.
Yeah, well, I have regular plans. I can say very simply that I was just absolutely floored and honored by this group to be recommended as the chair and then approved by the governor. And then I was in I can say this, people in Taiwan will agree with me. I was in the weirdest election cycle in anyone's recent memory. And so at the end of the year, I will not be on the county commission anymore. And since this position is directly tied to that, we'll be making a pivot, as we said a lot, and then we're going to pivot as our leadership role. So, and I couldn't be more excited. And I joked to Annalise that actually we should first ask me to consider doing this. I was like, it's just supposed to be Debbie. And so I think I knew, even somehow the universe told me it was supposed to be Debbie. So but that is Kelly's nomination. Yes, Debbie.
Yes.
And I will say, as far as the plant goes, we have you until December.
That's true.
And Kelly's gonna work with us on finding a new county commissioner, who has the destigmatizing, fair, just really holistic approach they have had that I think you're all so. Well, thanks.
Okay, so just as a reminder, we make recommendations to the governor's office on who our chair and vice chair are. And we need to get approval for that. And previously, we recommended Kelly and Sharon, which was accepted. And so procedurally, we need to select a new chair or recommendation for approval to come back, which will leave us with maybe a July interim, where Sharon will serve as our chair and her capacity as vice chair. But for this moment right now, I think we have a nomination for Debbie as the next chair recommendation. Debbie, can you accept that?
Yes, I was kind of heartsick, when I heard, from Kelly. Cause I was just getting to kind of get a chance to get to know you, and we were just talking about, did you come in, when did you know, and, I thought like Annalise just said, the heart and the passion and the qualifications and relationships you brought just seemed like that perfect match. And I'm grateful that you're gonna be staying on and guiding and continuing to do that. When this first came around, I had nominated Kelly. I was concerned about what you had kind of told me, Tony. It's like, hey, sometimes you're burning that candle on both ends because you want to really pay attention to your subcommittee. Since that time, I feel more comfortable saying yes because of the great co-chair I have on the prevention committee. And I feel really great about Dr. Tim Lynch, who is a new commissioner that we're fortunate to have on our subcommittee too. So I feel like I've got some good advocates, no matter what, that are gonna help with that. So I feel a little bit different place that I'd be honored and willing to serve in that.
Okay, and do we have any other nominations for chair? Okay, hearing none, do we have a second for Kelly's motion? We have a second, any discussion before we move to a formal vote
Or questions.
or questions?
It's a
Yeah.
little, bit of a big transition.
Okay, if none, and I'll listen to take the vote.
Yep. So this is to recommend Debbie Jones as chair to the governor. Priest, is join us. Okay, Caroline,
Yes.
Debbie. Yes. Eric,
Yes, sorry about that.
Fernando,
Yes.
Frankie,
Yes.
Jennifer. Yes. Julia,
Yes.
Katie.
Did you say Katie?
Yeah.
Okay, yes.
Thank you, Katie. Kelly, yes. Monta join. Moxie. Yes. And Mike joined. Sharon. Yes. And Shira.
Yes.
Stacy. Tim,
Yes.
Tony.
Yes.
Recommendation passes.
If I could just real quick, Tony, I remember meeting you, I had heard of you. Yeah, it was all, about this amazing guy that kept the agency going during a very difficult transition time and went through some people not understanding what your heart, and it was like all about helping people, and they might have thought, oh, because for 40 recovery, it has been a pleasure and an honor to, I know you're not going away, but just it's big shoes, and I know I could call you anytime between feedings and my time not sleeping, and it made a huge difference. And I just want to know that it's big shoes to fill, but I know that we're going to still be here to help you. Absolutely.
Yeah, there was the time I was begging people to come to the ADPC and get them on the commission. Things have changed because people were criticizing me that they weren't on the commission. I was like, wow, we have made it. That is the exciting factor. Like, we never heard of this before. Like, I've been talking about it for quite a few years. Awesome, congratulations, Debbie. Kelly, when you came on, you were ready to meet with me, and be a solid thing to you, and bought in right away. And I'm sure it's for your personal reasons, and really excited to have a commissioner here to help develop our credibility and also our effectiveness, and good respect for that, and county play an important role, and the work we're trying to do. So I know you. All right, Annalise, was there anything else with membership?
I'm kind of looking to see if anyone else would like to talk about a transition, we have a couple of other members who have kind of job changes that might lead to it, but we haven't confirmed a plan for everyone. Caroline, I don't know if you want to talk about your transition later this year, or if you'd like to wait.
No, I could talk about it now. Can you guys hear me okay?
Yeah, where are you
Yeah.
going?
Oh, yeah, no, I could, I took on a new role with my tribe. I thought I was going to be maybe retiring for reals, but I guess not. Yeah. So, yeah, I'm now the Chief Operation Officer for my tribe. So it's a 2-year
Congratulations.
appointment. Yeah. And one of the things that they wanted to make sure was the fact that I stay closer to home and try to probably withdraw from a lot of my appointments so I could focus on things. So it's beyond, me being the general manager at one time for the Health and Human Services, but now I'm overseeing, like public safety, public utilities, natural resources, education branch, Health and Human Services, and our High-Lookie assisted living. And so I just need to focus here. So I actually met with the tribes and I let them know the fact that I'm going to have to withdraw from several committees. I think I might be about 6 of them. And but I wanted to make sure that I had recommended someone who's been in the field, who has maybe not only some passion, probably a lot more passion than even myself. And so I am going to be recommending someone, and she's going to probably start the paperwork because I guess we have to reapply in June. And so I will finish the term out and hopefully that transition will be quite smooth. So that's about it. I will miss this committee because I guess maybe sometime I am beyond passionate just because of my historical history and working with the state for so many years and seeing what was possible. And then some changes happen and everything appeared to go backwards. So I'm, I remember when I first started on the Alcohol Drug Policy Commission, I did make a statement. If I didn't feel like it was going anywhere, I was going to resign. But we are going somewhere, so I never resign. So I do know this individual. I won't say her name until she actually submits and everything, just in case. But I think she would have the same type of, we liked seeing things happen. And I think this whole group has made it happen. So I feel good. I feel sad and I feel good. If you guys know what I mean. I feel sad that because, I made friends with so many of you all, but I feel good that you guys will take it a lot further. And that gives me a lot of comfort. So thank you.
Well, congratulations, Caroline. You were very supportive of me when I came on, and incredibly insightful. Will be missed, and appreciate you taking the time to, make a recommendation for us. That sounds like what September would be
So
the
we have-
confirmation.
Yep, so because of Caroline's excellent planning and the tribe's excellent collaboration, as Caroline said, fingers crossed, this person submits everything in time, we can get it through. So Caroline will stay with us till September. This person will be confirmed in September and start with us in October. Thank you, Caroline. We are appreciative and we are also so proud of you.
Any other
That's everything.
moving pieces? No. No. It's great. All right, so here we have next up. Here we got ad hoc data group. So I met with Annalise,
But we have this just wait slide real quick on the transition. So this is just to show everybody kind of what we have planned for the transition. So as we kind of all made very clear, Tony is still going to participate in this transition for this month and next month, within reason. The commission takes August off, and then we'll be back in September, new leadership, and Tony is continuing with the committee and continues as chair of the recovery committee. And we move forward, hopefully without some more.
okay, and then thanks, Annalise, for the before. So then, met with Annalise and then all four of us up here, had, and discussed how do we, consolidate a lot of the data and work that's going on at the state and to make sure people are streamlined with us and, came up with the idea, not forming another committee, having to find somebody to run it, and all of this stuff, but just forming an ad hoc, a temporary data work group. You want to talk a little bit more about the specific?
Yeah. Can you go to the next slide? So first, a quick reminder, so this is one of our infrastructure strategies from the plan to build and maintain data infrastructure to support decision making by improving data sharing within and between state agencies. So this is in our plan. And it just so happens, we're kind of, I guess, maybe like an umbrella with all of or the connective tissue, I think is how we've been explaining it with these three work streams here. So the settlement board, you'll see kind of in the middle there, was directed in House Bill 4098 in 2022 to fund a substance use disorder data system. The settlement board can allocate funding for that, but they don't control the data, and the same way we don't control the data. Then OHA has kind of these other two buckets that you'll see here in this report. So one is the OHA data office is building a health data warehouse, which is really kind of what we need to happen before we can start connecting healthcare data to the public safety system or across to other systems. But they have a whole lot of work to do before they can get there in terms of building data dictionaries and data catalogs with agencies so that all the data streams are using the same words and definitions. So OHA began that third bucket there, mapping recovery, which is also kind of an ad hoc internal OHA piece of work to start doing that for substance use disorder. And Mitch has been participating in that. So and the settlement board, as Fernando knows, had its own like advisory committee for this work. So over the past couple months, we did that thing that we talked about in the very beginning of the ADPC kind of coming in and saying, wait, there's a bunch of pieces here put together. And so we would like to propose to all of you today that we have this ad hoc data work group that will have hopefully some commissioners who are interested in kind of contributing to how the data is used or where we start with matching some of the data. And then we are going to propose to the settlement board data subcommittee that ADPC goes ahead and takes on that. So right now that's staffed through OHA Public Health, and of course will still be part of that. There's facilitators, but we volunteered to be kind of the glue that holds that together. And then working with Ebony and her counterpart in Medicaid to take this ADPC piece and kind of plug it into OHA for a shared governance structure. So I know that sounds like a whole lot of words, but the goal is to have just one work stream basically is the conclusion here. And both Ebony and Emma, the Medicaid director, are supportive of this concept and supporting internal staff to move it forward. And our hope is that the settlement board resources might bring some resources to it and move things to move things forward. So The question for today is, we talked about, I don't think, because it's not a committee, you don't have to officially approve it, but is this a concept that folks support, or there folks want to volunteer? And I will open it up, Fernando, or Ebony, if you don't feel like you have to, but if either of you want to add anything to that, about this.
Go
Oh,
ahead.
can,
Go ahead, Ebony.
oh, can y'all hear me okay?
Yeah.
Yeah, no, I think the one thing that I will just say is that, it truly takes a village. And, when we think about our system and when we think about kind of, making sure that we have the information to understand, where our resources are going, the impact, the needs and the gaps so that we can have meaningful policy and strategy and resourcing to see the change and the aim that we're looking for, we have to think about it from a collective standpoint or a system standpoint. And so, I just will say that I appreciate being able to kind of zoom out, if you will, to really be able to kind of capture the ecosystem perspective, and just appreciate the continued efforts to, be more efficient and less siloed. So appreciate this opportunity.
Well, thanks, Ebony. Fernando?
Yeah, I was I echo everything that Ebony just said, and I'm not gonna volunteer because I'm already a volunteer. And I absolutely support this concept. It's such a honor to be in a spot where we've worked so hard to create the strategic plan with a high level perspective of busting down silos and creating a more holistic system for the state. And so helping these two groups working together to help kind of make some recommendations and to also kind of keep that purview of like building the system and always kind of referencing back to the strategic plan is such important work that it's needed. So if anybody wants to help join and volunteer, I would love to have some. Let's do it.
Questions? Yeah,
I'm probably stating the obvious, but I've been digging into data in another realm this past week on gun violence prevention and, I think the big unknown is, are we gonna be able to answer the questions we're gonna have for dates? That's just being incredibly thoughtful. How we set up data sets so that these truly are tools for us to make policy decisions. Settings. I realize it's much easier said than done, as I'm taking it just better done. Thank you.
I have a question. I love this type of work. I'm just wondering.
I think what, twice a week, 4-hour session. I have any idea.
Tentatively hoping to be in August. So we have a meeting with the settlement board, existing committee next month. I hope is to kind of bring everybody together in August. And then we're thinking more like a quarter. That this group will very much be like offering their subject matter expertise, Senator Reynolds, for exactly the reason you're saying, like really like, yes, that data is fine, but is that useful to answer the questions that we're trying to answer, which is as well. So we're thinking, okay, and I don't know when yet.
Okay, if it's in for me, then I could probably do it. And quarterly sounds okay, unless there are also sub groups inside of it.
Mark, you know it so well. It's so well, yeah, exactly.
I'm always been awesome. I've always been. But
Okay, I'm here.
Sure, Michelle.
Excellent. We have lots of.
Julie, you want to go through? Yeah.
I just think this is,
Is too late.
I would love, you can correct me if I still am learning the systems, but I think, with the block grant with impact. And all those, instead of we get to these committees and we get an ask and an opportunity. And it's like, as we were talking about before the meeting started, it's like, oh, this has happened fast, but when we have something like this that's put together and we already know, it helps us be more shovel ready, so to speak. And so I just think the climate we live in, we've got to be that nimble and ready and be able to tell the story of what's been happening in the last few years. So I think this is a great idea. So does that person driving.
Yeah.
I think that person.
I got it.
Want some lunch. Okay, so it looks like you captured some interested individuals. If anybody else is interested, of course, I'm sure they could email Annalise or we'll get some communication about it.
Yeah.
Great, and then just for my own clarification, Annalise, is the goal of the committee to bring together data sets that already exist that can be analyzed more holistically, or to create new data sets?
So there's a couple pieces to this. So, the best thing that I can kind of say is that the newest version of those things has three goals. One is to figure out where everything lives, who has it, so that internally we can get access to all questions faster. One of those is also to just make sure whatever we provide publicly now is there, so that those to your point that you don't have to wait to get data. The big thing that I've been talking to the core group is figuring out early on if we can come to the commission and say, like, what are 5 questions we want us to go for with the answer first,
Okay.
and have those be the priority and figure it out, because I think the big fear is there might be questions that y'all might ask that might be possible with our current data, or is it distributed because it's in time periods and so we don't want to give you that. So yes.
Okay, on to more data.
More data.
At least this group cares about it. So we're gonna have a follow-up from the previous meeting on our comprehensive plan and outcome measures. Was passionate about it, wants to get it right, and appreciate the staff taking time with all of us and listening to all of our concerns, our criticism and our recommendations, some that are good, some that aren't necessarily all the time, and coming back with us with some help. That's up to Willow, to Wes, Will.
I think I'm gonna kick us
Oh,
off.
Annalise
A
might kick us
couple,
off.
yeah. So we can go to the next slide. So folks might remember this graphic from last month. Maybe you don't like it. But we left it in, those arrows. Primarily, so just kind of going back to where we were last week as we dive in today, but what we're really trying to figure out here is, so again, taking us back to what our job is, the ADPC, to really think about what are our spheres of influence, what are the levers that we can pull, right? So we can give guidelines to state agencies, we can draft, and we're gonna talk about this later today, like guidelines that all state agencies can use. But that outcomes piece on the right-hand side, I think one reminder is that you all are really the only ones looking at that. So individual agencies aren't really looking at their own, at cross-agency outcomes. Nobody sits and thinks about, I mean, a lot of people think about overdose, but like prevalence, right? Like those kinds of things. And what's influencing it every year, like you all are the only ones that think about that. So that is why we wanna sit here. We're probably gonna keep coming back to you with some of these questions about how do we measure our progress? And so we're gonna talk a little bit today, go to the next slide, about, why kind of the high level indicators that we've used in the past of aren't enough. And then Will and Wes are gonna give a couple of examples from work we're doing right now that, to be honest, are a little bit easier when we're looking at new things. or we're putting guidelines where there aren't guidelines before, there haven't been measures set, it's a little easier to come in and say that. In the treatment realm, the work that Katie and Mitch are doing, it's gonna be a lot harder. Right, because there's already, you know, a bajillion contracts, grants and funding out there that we're gonna have to kind of say, well, what you're collecting is good, but a little bit something different to answer the questions we're trying to answer. So this is just a little reminder. What we're working towards that first beyond recovery oriented system of care. I highlighted a couple things here just for us to like be thinking about as we go through this. Budget policy priorities for participating state agencies and the most effective and efficient use of funds. So, you know, right now we're gathering that baseline data to say this is how the state agencies spend their money. But what that's not going to tell us is, are the things they're funding effective? So that's really kind of where we're trying to go with you all on this, of how we develop those measures in the middle there. That tell us that we're doing a good job, because our big three goals, of course, are reducing prevalence, deaths, disparities. But you can't really measure that with an individual program, right? But it takes time. It's a little bit harder than that. So what are the things in the middle? So next slide, I'm going to turn it over to Will to talk about, this was a question that Tony asked. Why is prevalence and low not enough? And some of you might remember some of these pieces we've talked about before when we had a disruption in the data and we realized that we didn't really measure prevalence.
Cool. All right, thanks. Yeah, so we touch on this data every now and then, but it's way more exciting when we do it. So the big three, we're talking about substance use disorder prevalence, overdose deaths, and disparities for those measures as well. In the 2020-2025 plan, we did analysis of population level areas, but we didn't go much further than that. 21.6, you know, it's a big number in the earlier screen. That's basically showing about 1.5 or going to substance use disorder. And there's no reason it very much at all. At the highest level, the comprehensive plan should move things. But at a lower level, the agency is working towards things that do prevent substance use, overdoses, prevention efforts, access to treatment, naloxone, and increased reach of recovery centers and care services. But there's no way to directly tie these to those big goals. Like, for example, we added a recovery center. We have no way to say that overdoses are going down by X% because of that recovery center. Like, it makes sense bigger now. I'll have a way to. You know, go next slide. One point we wanted to clarify about that 21.6% substance use disorder prevalence is that this is based on surveys, so there's always going to be some error in it. So, like, maybe, for example, the estimate was 21.6, but the way it's presented sometimes is it's more like maybe like 40.8% and 22.4%. That's like how best it gets. That's the confidence interval. So, right, based on estimates, and for many reasons, this figure can't be tracked over time. And I just want to point out that what we can say about this figure is a lot of people have substance use disorders. 1 in 5 is a lot. And we can break it down into age groups a little bit. It's like 25, much higher. What we cannot say from this data is that substance use disorders have gone up or down over time, which makes things inconvenient to manage the relatively flat. Just a couple reasons why we can't do that is that, SEMTA changed their methodology in around 2020. And, Oregon's prevalence went from about 10% to 20% over time. And that did nothing changed about our substance use. What happened was is they finally adopted the some law. And so, what happened is there's, a bigger pool of people being measured for like mild substance use disorder, which, is mostly gonna be alcohol. So when we're talking about prevalence, then we know that a lot of measures will get by substance use in order to prevalence is going up. Probably things track along like more overdoses, more deaths from alcohol use, hospitalization data, there's just a part of it. These things track together. So if one of those measures is not adequate, it's more appropriate to withdraw. We won't get substance use disorder prevalence over time, but all of that together can tell sort of a richer story. That's one thing I want to hear too. Okay, the point. Population measures are helpful and necessary, but we need to measure our work with other outcomes too. I think that's kind of what we're looking at. I think that's all. Yeah.
Are there questions about that before we go into examples?
I just have a question. So this came up with that I was doing with our gambling prevention. And we were doing these community readiness interviews to see if people thought it was a priority. And they would ask me, well, what's our percentage that we think had this problem? And I asked the state and they said, well, we don't really have data. So we go by this formula that says if your population is this, then this many people probably fall under that. And then out of those people, you get this. Is this kind of the same thing? It's like they're doing a statistical analysis.
Essentially, this is like a couple thousand households get 35%. Probably very few in Moscow County.
Right.
Unfortunately, that's just how it goes when we want to break this into geography. They give us like 6 really weird. Not a lot we can do that.
So is it better what you were just kind of suggesting that since we don't have a huge amount of confidence in that number, but if we could really track the other numbers, that's gonna tell us a little bit more bigger picture because we know they'll go together.
Yeah, because we'll have other stats.
Okay. So it's making, or even just a whole state, it's making that number make more sense. And have more credibility if these others are known levers that seem to move together.
It's us thinking about what are the measures we use, right? So, I mean, mostly the measures in the last time were these really high level measures.
Because something I left out about that 21.6, I think is really important for this discussion, show how useful that figure can be. It's also includes people who have not been officially diagnosed with substance use. So they're going to have the same symptoms. So there's no way we can, fight going into services. And so still very useful.
If we know that the difference in prevalence was based on a change in data set.
Yeah.
Do we have access to the data set to subtract out the wild business so that we can compare the trends that we can?
So it used to be, and I'm gonna forget the terms, now we're talking about ours. It was classified as dependence and abuse and abuse on board, they don't matter. So it's not.
Well, so sounds like you're saying right now we can't track year over year because the methodology changed. how long before when he, under the new methodology, sort of looked over and infer some sort of,
Yeah.
reasoning from it or thought from it?
Like, I personally wanted to like put some information out this side. And this is not, I mean, people are doing different, it's just the fact that people are in there listening to people who want to. I wanted something a little more meaningful that I like would base program decision on, right? I feel like I would need more like 4 or 5 years. When you're not measuring like history, you're comparing that is to the person. Because we can use statistics to do that, and you know, when you see it move up the growth rate over time, it's like, you know, we talked about that error that can be there, and it's like, well, you have these two figures where there's both error, like how are you compare these things and it's off like that, but so I would say several years, and we're caution that comparison.
And compared to these other indicators, possible inflation,
Right,
arrest data, overdose, that, you know, some other things to sort of get a more holistic picture. Okay.
Fernando.
Oh, Fernando, go ahead.
Yeah, Will, my question was similar to Tony's, but a little different. The directionality in 2020 means that the prevalence doubled overnight. Did other states see a similar doubling overnight with that change, that prevalence? Do you know?
right, like maybe there's a different sort of mix of symptoms in different states, I guess.
Yeah.
Could be, I don't know, I haven't really looked into the change, like, you know, state side by side. That's a good idea. I could check that out.
Yeah, and I was also wondering, this estimates at 20% that 1 in 5. That estimate seems rather high, compared to, or is a 1 in 5, maybe it's a better way to ask the question. Is a 1 in 5 prevalence rate for the state of Oregon, compared to other states, seem like the number seems high? I'll just say it that way. 1 in 5 seems high for a substance use disorder.
Yeah, so that's, you know, that's what came from the national surveys, from our households, from people who answered it, it's people 12 and older. And, I think that, so, because like previously it had been around 9 or 10, right? And maybe you think that's the more accurate answer. But I think what happened, what inflated this number, it's not inflated, it's just being measured a different way. What happened is that it's much more inclusive of mild disorders where you only need, what is it, 2 or more of the 11 in the DSM-5 to count as, you know, being, you know, someone with a substance use disorder. And so, you know, I've kind of compared the old numbers to the new ones, and that seems to be what's not taking place. And it does have different implications for treatment and, you know, what might help those with mild substance use disorder. I think the other part was states. And I have not compared state to state because of that, you know, error thing we're talking about. But we can compare is to the nation. And we're significantly higher than the nation, which is I think around 16 or 17%.
And we were higher before. Like,
Yeah, we were higher,
right, and didn't the national
Yeah.
average roughly double?
Yeah.
So you didn't compare the states with the national average.
Exactly.
Yeah.
Yeah, thank you so much.
I'll go ahead, sorry.
I was just saying thank you for the clarification on that 20%. I know you and I've talked about that before, so it seems like what this number is, it's sorted in the people that have maybe 1 or 2, well, 2 symptoms basically of the 11 in the DSM probably. So
Yeah, exactly.
yeah, got it.
So let me ask you a question. These surveys, how were they conducted?
Well, so both, that's another reason we can't, like, I don't know, part of that change too. So traditionally, someone would visit someone's house or residence or, you know, there's certain, group living situations where they would, you know, surveyed and some where they wouldn't, like, there's some institutions folks. Anyway, it's a, it's a long survey, the documentation to try and figure out what's going on is the author. But yeah, so they'll, do the survey at the household, people 12 and older. And now they've added a sort of a virtual survey to them. Last I checked, they were, was either doing half and half or they're transitioning to highly virtual. And people can actually answer questions different virtually as they do in person. And so when that was introduced, couldn't compare. So anyway, what I'm getting at is, it's conducted by, predominantly virtual settings. So,
And so my concern,
Well, if they, that's where they get the,
Not parts.
no, it's not
okay.
part of it, it's where they get the data, where to send, or where to send people, or where to send the book, invoice that has to be. Student census.
so my concern is that marginalized communities, a lot of folks ain't gonna take time for any long survey, for one. A lot of times, marginalized communities are not gonna fill out or let somebody into their home because they don't know who you are, for one. They don't know what you're asking for and who are you reporting this information to, the untrust of folks wanting to do surveys. So I'd really like to, I don't even know if I'd like to see it, I just don't, but I don't believe it. I don't believe it enough.
yeah, I mean, and that's where, like, we could do more slides about what the limitations.
Yeah.
I'm on board with you, but that, also. Okay, no.
So we're not, I'm sorry, do we, we're not believe the numbers because they're too high or? I think they're too low. I see, that's what I would think. I think there's especially when you look at Native American communities, Latino communities. Latino communities, African American communities, I think these numbers are too low. Because we have people, I also go to this, meeting where they're talking about, given data, right? On, what is it? I forget what it was. But anyway, I asked about the demographics, right? And when you ask about the demographics, they have little to none. So we're the Black folks, we're the Latino folks, we're the Native Americans that we're suffering the most from these diseases. Because if you look at our population in this state, we're small populations, but we have higher rates of overdose, higher rates of mild substance abuse, higher rates of high substance abuse where we're dying in the streets. And those are not, for some reason, are not being captured. And it concerns me.
Well, I think you know, right on, some people do not want. And like, if you were asked me what this, you know, what we can bring to a conversation like this from this data source, I'd have to go to the national level, which is, you know, if that's problem. And yes, I think every number, like this, that we present, they should be a part exactly how we do. I am hopeful that some of the data we share in this presentation, we are gonna be about,
Well, don't think I'm jumping on you.
oh, no, just, you're not saying so.
So Will, you're saying prevalence is not enough, and we have to contextualize that with some other data to get a full picture. And I assume you guys have some other data you thought it through.
Yes, sir.
Okay.
But it's important to have a number. Or that we can say, hey, whether we like it or not, at least we've got something that we can start shooting and that we gotta change. I'm sorry, wrong, place for shooting a number that's out there. A benchmark, so to speak, and we gotta at least have something.
I'm talking to a friend or something, and whether that's 18 or 24, who said, hey,
Still
we
hard.
got about 1 in 5 people.
Yeah.
But
It's
show
only
us.
we're only looking at prevalence in terms of the largely by population. Any changes to that prevalence that would come about and also only in terms of the.
Or I'm happy to look a little more into, like which households those.
Quote from NISTA. For the study, household addresses are randomly selected through scientific methods.
I participated on these.
I did too. Yes,
We got it.
I got it.
Very great. You know, like, I got halfway through, and paranoia kicked in, and I went, better start over answering, so they don't think I was lying,
Yeah.
so.
It's long.
Yeah. So what,
Lost the order.
yeah, no, it's all good.
This manual, so, like, the manual to look through the survey is like 800 pages long.
Oh,
There's all these like
gosh.
additional questions. And then there are a couple other documents that are a couple thousand pages long. So I do want to say that these are brilliant people doing the work that can put it out. So.
What other,
Well, so now we're gonna get into like, what's next?
what's next?
Yeah,
Yeah.
what's next? Yeah.
So I'll start us off. So if we go to the next slide. So y'all will all recall, in our meeting in May, we went through an exercise with of people, hypothetical people. And we walked with you through examples of how would we support this, or how would we know if what we did to support this person. That was really critical for us as staff, start to experiment with some centralized, unified frameworks to tell the story and to start to park the data underneath those frameworks. So what you all did, it was an example, but it also it's helping us to come together to show, one, that the comprehensive plan is cohesive, that they fall under these neat frameworks. But also to start to think about and provide evidence for what you all have recommended as strategies. And so if we can do those two things simultaneously over time, you all set us up perfectly. Senator Reynolds, Julia, Debbie, I'll set the team. I think everything in team hall terms right now. So y'all set it up because that will allow us to guide funding decisions. Data collection, to y'all's point, data collection, how we data, and how we start to begin to evaluate some of the work that you all have put into the plan moving forward. So this is really exciting. And the examples, there's a whole lot of group work we really appreciate it. But on the other end of that, we use that information to start to build out how do we link the strategies with some of these conceptual frameworks that are linked in evidence to these broader. So again, for everybody, just to remember, we use two frameworks. We use recovery capital, and what we kind of think of as the other side of the coin of recovery capital is positive use. So I'll just set this up. Will and I are going to take us through two strategies where we apply the work that you all did last month with the work of the frameworks and show you how we're making incremental change towards the goals that we're trying to.
Yeah, so we can go. We move right on to the next slide, that's fine. Yeah, hopefully everyone has their packets. I'm gonna share a bit about how that happened naturally, sort of in our recovery committee. Actually, I should just say, so please don't feel like you need to read and take in this definition. We're gonna work from it, but it's just there to show you we did it and highlight. Don't take too much of time. So. What's happened is students in recovery, it feels like they've naturally kind of fell into sort of a potential framework for measuring outcomes. And let me back up a second. So the recovery committee has 4 strategies or priorities. And the first top priority that we decided was approved by the commission was to expand the recovery committees. Up until this past May's recovery committee, there had never been a formal definition of a recovery community center. Well, we know what they are. We know we're in a recovery center right now. It's just a definition was never put into place for that recovery center. So the recovery committee spent first 4 months of the year on this task. Last month, they finalized the definition, which is up here. And in August, they'll also need to added to this definition. So for the recovery committee, this definition was the first step in all of the work that we're going to do around the definition. And really essential in any progress on a framework for reporting. Obviously, so we got the definition. Given this new definition, and we feel it's appropriate to start talking about data outcomes as they are attached. So, whether you're looking up there or at your packet or on your computer, I think you're going to see bolded text in that definition. So the bold pieces are recovery centers being non-residential, peer operated, paid director, recovery staff, drop-in hours, peer support. The people at the center are those facing challenges or obstacles consistent with recovery from substance use disorder. Who don't have to be diagnosed, or those in remission. Centers are typically free of charge. If the community center does not offer culturally specific services, specific to individual needs, center must be able to refer them to such available services. Center is here. This is the heart of this definition to help participants build recovery capital. They do that by offering social activities, fostering relationships, navigating community resources, connection with their social services, mutual support meetings, funding resources, advocacy education, and go on to the opportunities. So as it turns out, all of those pieces in bold, those are the things that we can measure about a recovery center. So that's the direction we're going. And if you could move to the next slide.
Well, Fernando, what is peer operating?
Oh, you know what, that's been sort of up for debate because we're trying to figure out, well, peer run, peer operated, and such. And so peer operated, and I think we sort of settled on actually, let me back up. We decided we needed to talk about this more, but where we left it was that peer operated would be that sort of the director of the center and the staff would have that experience required.
So if I can just add a little zoom out point as you transition to the next slide. So here we're talking about a program, strategy in the comprehensive plan that you all have said, this is a effective strategy to address substance use disorder. So now we're defining what exactly that means. So the expectation would be if state agencies fund recovery centers, that it will have these basic elements to it. So just trying to zoom out further.
All right, yeah, if we could get to that Next slide, great. Yeah, so this is a little bit of fun. But the first thing I really just want to point out is that middle box, right, the big middle box. Those are all the bolded text from the last slide, those things, so that we can measure. Above that box is a definition. I'm just trying to show that the definition is, you know, where those items. And so each of these can be broken into more granular measures, right? So I just grabbed social activities, for instance, and then like if the center was gonna measure something that, you know, showed the, or, you know, met the social activities piece of the definition, that they share number of activities, they host, what time, frequency, number of participants, and more. And this can be done for each of those items as well. You know, I include like non-residential and peer operated and stuff. They're yes or no questions, but that still is a. Sort of at this point, I want to mention that we are kind of talking about measuring two different things here. We're talking about measuring things at the center level, activities, or such. And then we're talking about peer support, which if someone enrolls in peer support, we kind of start tracking and measuring that person's progress at different levels. And so I think we found a way, or we're near towards finding a way in which we can measure center activities different from peer support activities, but also measure them together. This is so something about this slide, for some reason, my last update didn't sync and it made it into this presentation without a few things that I wanted on it. So I'm sorry about that. I want to just point out where the commission, because the work has been awesome, and you know, the commission there approved this comprehensive plan with the recovery component, and one of the most prominent pieces of that was this definition of the representation center. So let's start with the definition. This middle box came from that definition. And then this last box, it says things outside the definition we want to measure. And it's supposed to also include items from May's mission. It says what else, and what I wanted to put in that box. So it was really neat because what the commission came to last month, there was huge overlap between that big box that really makes us feel good about that definition. A couple things that the exercise groups added, or you know, sort of measurement, recovery, maintenance, transitions from frontier and rural distinctions, focus on social determinants of health, transportation, and work. You know, with all these measures combined, you know, our goal is to tell the community about the recovery centers, and it can be that simple. We can do over data, story, report, or survey. Going back to that big box for a second, we're trying to measure recovery capital, and that's going to be on the next slide in a second. Measuring recovery capital is at the heart of our plan. We're talking about these granular level measures that we can measure, like activity, frequency, and participants. And we can do that, and we can also show that can be attached to things like without capital, which is that high level of the big four, because the big three. So if we can move to the next slide, so this slide shows more of the framework. And you know, for RCCs, like we talked about, it's centered recovery capital. Discovery capital is the focus of the RCC definition. Yeah, it's like. You talk about recovery capital so many ways for so long. It's not something that pops up, but this is the first time we consider it in our outcomes. Not the sufficient level. And recovery capital is simply the sum of resources someone has to aid in their recovery. If you look over to the right, to that column recovery capital, you see the 4 dimensions of recovery capital. And that's what we're trying to do. It's quite simply, just to let you know, it's true, more recovery capital has been shown to align with stronger recovery. So there are 2 goals here, and I just want to pick apart recovery capital a little bit. One of those is to show the extent to which NRCC is the optimal place to build. It's like, at the end of the day, recovery capital is a personal measurement. So it doesn't make sense to say recovery capital has this much, it doesn't make sense to say that a recovery center has this much recovery capital. It can become a better place for someone to develop their own recovery capital. So that's sort of one part of it. And then the other thing we've considered, in our measurements is the individual's progress in building. And what that would have to look like, as far as we see, is someone enrolled in services at the center and, in such a way that they could be given survey or screenings, well, at least one, it's fine. Okay, those capital. And if you're into that kind of thing, there's been lots of support this from people on the recovery committee. And if you're familiar with Part 10, that's I think a lot of people tend to bring that up in this conversation. It's a question, screening, the survey, whatever you want to call it. And then that actually can be used to measure someone's recovery capital over time. All right, so we look left to right. Blue box on the left, those are the measures from the definition at last month's exercise. So these are attached directly to the more granular level data in the middle. That's what we're going to be measuring correctly. And each piece of that data that we're going to be tracking can be mapped to recovery capital, which is what we want to report on. So by counting, measuring, reporting all this information in the middle column, demonstrating RCCs, they're the ideal place to help people build recovery capital or may not come. We're done there. Sorry. One thing I want to say is that there's a couple of big strengths here that are complex and talking through a lot of terminology and doing this mapping and stuff. And I guess at the end of the day, I'm looking at this at this point and saying, I really think we can do this. I think it's attainable. Yeah, I'm really excited about it.
Yeah, maybe.
And then we can use the questions. Yeah, that's what I was thinking, yeah.
Okay, so for the second example we chose the OYAS strategy of the school-based early intervention treatment and recovery pilot. So we don't have a definition per se as the recovery community centers do, but we did have grant language that kind of spelled out what the user wanted from a pilot program and how we translated that into the grants that went out to 8 communities throughout the state. I did not put my book in. That was very good. I needed that, but you'll see them on the next page. Pilots provide capacity and planning grants to communities interested in developing a model of support for school-based early intervention. outpatient treatment, recovery student services for their students. These grants would support school-embedded, cross-trained, licensed or dual credentialed professionals, provide evidence-informed and/or culturally responsive screening, brief intervention, outpatient treatment, and recovery services to youth. The pilot seeks to modify school discipline policy to support increased staff knowledge and capacity, improve educational outcomes, and support students with tier 2 and tier 3 behavioral health needs. That's school speak for youth who have a behavioral health need, and those who are tier 3s in crisis. So that is what the grant aims to do. Go to the next slide. So just like Will, and here's kind of the note that the commission influenced that, right? So you all supported the OEA's ideas, some of you sat on the OEA and informed what we were supposed to take forward as a goal going into 2026. And then you all helped us build out some additional measures. So some of the things that could be measured within the grant as it was, things like the number of screenings, the intervention, treatment utilization, whether you have cross-trained professionals, staff knowledge, school policy changes, educational outcomes. So that I think is a really important piece for us in bridging the gap between the work that we do on the behavioral health side. What's important for school? So what is going to get us inside of a school to make our case of why these services are needed? So some of the academic measures are attendance, disciplinary referrals, expulsion, and school connectedness. And I think some of our academic measures are also really vital to measuring how memorable these programs are and thinking about schools. I think folks, it is natural to one thing. Oh, it's in a school. That means, you're really trying to embed behavioral health in an equity framework. That's not necessarily true, right? Schools, there are major barriers to services within schools for our populations of color, for young people in rural communities. So thinking about how do we build in some measures that show we can overcome some of those barriers within a school. So that's disciplinary diversion, expulsion diversion, transportation, things like that. Really help us to kind of plan the ship, so to speak. You all added some metrics that were not necessarily not thought of, but also just in addition to what were kind of added to the pilot. So MOUD initiation, family intervention utilization, grades to get more granular with respect to educational outcomes, adult student connectedness, measure that through the SHS, student health survey, and increased activities or peer support. So go to the next slide. This is how it all kind of shakes out. So we use the positive youth development framework on this, considering that not all young people who are screened necessarily have a substance use disorder. So thinking about how screenings can be preventative, or if they were caught one time with substances on campus, maybe they haven't even used it yet. We don't know. So thinking about how we can think about this in the prevention framework as well. So yeah, we're really able to take what you all put us to neatly map this positive development. Say what we're doing with respect to the program parameters within the school-based pilot influence these measures, and these measures then help us to build let's say capital towards positive youth development, but we're just the measures of positive youth development. I think the other thing I want to name for these frameworks and why this is important is these are adaptable based on the population they're trying to serve. So PYD, positive youth development, might not look the same for a single tribe as it does for the county in which the tribe is adjacent. And so it's really important to think about the frameworks as ways to guide us under this kind of universal vision of what we want to see for our young people. And it's the same with recovery capital. So what are the levers and what we measure depends on the context of the community. And we can start to think through, these are great measures for this specific population. Now we can land it into this overall arching goal of increasing positive development.
Okay, question, I have the first question, so. From understanding what you just said, Wes. We have these 4 pillars of positive development elements. Yep. And then you were able to get more granular. And that's sort of the middle box there, really defining core success metrics within those categories.
Yep, based on program elements and based on what you said last week would help, like, let's just say we had 2 young people in our examples. What you said would be helpful and supportive of the young person. Both of those examples, we were able to map that to the employee as well. And also go back to our grant teams and say, okay, well, maybe we should start to think about measuring these things.
Other questions?
At what age or transition point would a young person transition from positive youth development to positive capital and also measure?
I actually think that's a great question. I think, so I've seen positive youth development used up to age 25. So kind of what we've thought about is with respect to positive youth development through adolescence, really. Less so in young adulthood, but it's mostly been towards like high school age, middle or high school age young people. I don't think there's nothing within positive youth development that doesn't apply to young people that are age 20 to 21, especially if you're thinking about it as a framework. Good measure, maybe the measures are different that measure.
Yeah, I was initially thinking if somebody started as a 15-year-old and continued to develop, we just kind of like these ones, and if they started at age 23 or something.
I think the other thing that you'll see for this transition piece is that there is major overlap between positive youth development and recovery capital. And so how do we start to harness that for our 25 and 26-year-olds to make that transition?
Other questions, comments? Yeah. And summarizing.
Tony, just one.
Okay, yeah.
So this is not sense. I think the other thing I wanted to say is this is not sense. Like these program parameters aren't necessarily set in stone. And we'll be working with you and all the committees as we start to develop out our strategies to do similar exercises, right? And I think we use these because recovery capital is pretty far along in the definition. We have grants out, those pilots, and so you're already giving evaluators to start to talk to us about how to evaluate these programs over the next 2 years. So these are just examples, and we will come back to you to think through this for all of the strategies, especially the strategies that are creating something, because that it's an easy place to start to kind of measure the scratch.
But they're big, nice, big key ones, so you can take it, you know, as you want to start getting deeper into what's a program.
Right.
What's a specific strategy
Right.
that fits under that.
Right.
And then having like a 1, 2, 3, 4 that you have more off the right, so that will continue. So, yeah, I think as far as structure wise, it really, you can start, okay, but this year now, this.
So then going back to earlier, what you had said, Will, you know, with prevalence not being enough and we need these other key indicators, textualize everything, and we need as much information we can to draw a conclusion about where our populace is going to stand in relation to substance use disorder. But then this is an additional layer to say, we know the investments we have are working. Aside from just the prevalence shift up and down this other stuff, like, so maybe we need more of it, but we know our investments right now are creating this sort of outcome in the meso data, you know, structure or whatever, kind of in the middle of it, we can look at it and say, okay, yeah, this is working for this, and overdose or, you know, hospital visits, stuff like that. Is that kind of framework we're moving towards?
And then eventually, so we're trying to really start from this individual program level, like you said, because things are new to see. But we need to know this because then we have to look at everything in a combination, right? To start to be able to really say, okay, what's not working in the system, right? Like a lot of money going out the door to million treatment, right? What's not, right? Then we have to start to look at everything in collaboration. I think overdose is a really good example. People have been talking about it a lot lately with national numbers going down. And it's, you know, there's a lot of conversation and questions about like what exactly was the combination that resulted in overdoses going down. It's, you know, we don't have the information in front of us right now because we haven't organized in this way. It's probably a combination of things, but which things like meant more, right? It's hard to tell. And part of that is we've been missing claims data. So remember, we will start to have an all claims analysis and again, that's being provided, that's how effective it is, but that is like a piece of the puzzle that will start to help us put it together, but it's not working.
And this data is going to be good for the commission to look at the investments, that's right, in our strategic plan and make changes if we need to, build up the success we have, or, you know, revamp our plan.
And start to recommend measures so that we can be evaluating things across programs instead of this over here, that over there, this year and this year. We can pass it on to friends.
Well, and I mean, because there's two evidence informed recovery capital and positive development that you can stand on already, so you don't have to worry about that. And then I think it gives us opportunity when you start looking deeper, you know, maybe overdoses of fentanyl have dropped down because maybe, you know, the Narcan working or the supply is going down, but our meth, you know, what was the unintended consequence that happened? Yeah, and like we just heard the other day, it's like cocaine is making them have that, and it's like, yeah, we have to help people. Drugs will change. And go whatever's cheaper and easiest to get, so I think this lets us have a much more take a look at what's happening and what could happen in an asset environment.
Okay, any other questions, comments from commissioners?
I have a question, I guess, because some of this is preventative, right? I mean, a lot of this is preventative, but with early identification of those, either at risk or in addiction. So. You know, just really,
Yeah, well,
it
it
should be a very big preventative.
What could come using this model, then it's like, hey, we want going down before that mother, that person is even thinking about getting pregnant.
Yeah.
You know, what would need to be there?
I think that's probably like ID because you can capture a lot on broader, very upstream prevention.
Right.
While also capturing the strength and type of factors for young people who might have a behavioral health diagnosis. And so I think that's really important for us as it kind of bridges the gap from prevention to early secondary.
Well, I like it because I feel like it's promotion. Then maybe we won't have to for promoting all the good stuff.
Yeah, but we also want to wait 20 years.
Yeah.
Right.
Yeah,
Right.
yeah.
You know, the it's working. Yeah.
Yes.
Yeah. Okay, thank you guys so much. We'll move on to committee updates and we'll start with prevention.
We had some really good meetings. Wes has taken on some heavy subjects. I think we are close to kind of having a beginning framework of what would need to be in a center of excellence. Who would need to be involved? We really stayed away from who runs it. Just that isn't a question that's even on the table. It's kind of like the what we just looked at this. So a lot of work on that, and then I believe next, if this month, we get here to Third Horizon. About the work that they've been doing on House Bill 3321, report as far as all the organizations reporting back. There's tons of surveys going out right now that it's, I think, hitting every door.
especially as trying to figure out what is primary prevention, where the money is. So I think for the next 2 months, we'll have some exciting, things to do. Wes has been great about, wrangling wild feral cats. I think that's what our meetings are. But I think we got really good about the last one, even better than what we anticipated. So a lot of stuff coming out, and Senator Reynolds, as you spoke, that really is looking at that upstream, even upstreamer, if that's the term. Thanks.
Oh, yeah.
So we are gonna be, meeting, we meet on Wednesday, for, you will be having a 6-month update. So we will be going over some pilots, some work that was at the Oregon Department of Services and, last one. The recovery definition. So we'll be going through the last 6 months of work. It will be a celebratory meeting. We're also appointing 2 new members, a family member and a youth member. So 3 more folks added to our OEF family. Yeah.
Awesome. Treatment.
Hey, so for treatment, at our last meeting, we continue to work on implementation of the comprehensive plan's treatment priorities. In addition to reviewing our ongoing focus areas, we spent time discussing the provider assessment and identifying what information can best or only be answered by providers. So questions related to treatment access and capacity, withdrawal management and residential treatment capacity, referral pathways and care coordination, data and metrics, and then how the provider feedback can help answer questions that will ultimately support implementation of the comprehensive plan. And then our next meeting, which is this week, I don't even know what day of the week it is today. We'll continue refining those questions and identifying the most useful information to collect from providers to establish baseline measures and inform future recommendations. Thank you.
Thanks, Katie. Health and safety intervention.
Yeah, so we are continuing on the naloxone train. Last month, we talked about expired naloxone. We had some folks come and speak to us from the Naloxone Project, which is a national coalition that goes into states and works on legislation and just collaborates within the harm reduction sphere to help with naloxone. We had some members who are interested in potentially starting a chapter of that, which would be like a good advocacy arm in a manner that the participating. So that's a potential thing going forward. We also had Dr. Sarah Present from Clackamas County talk to us about the Oregon contract for expired naloxone. And we had a rousing conversation about what our plan is moving forward. More to be revealed on that as we have not made a decision. And then I believe next month, our next meeting, we are supposed to hear from Save Lives Oregon and the results of their member survey, their survey that they give out to the folks who utilize their services and hear more from them. And as a reminder, we changed our cadence for our meetings. So we no longer meet the 4th Tuesday of the month, we meet the last Tuesday of the month. That only affects 3 months this year, but this is the first month that it will affect. So we will meet on, you can see the 29th and the 30th of June instead of the 23rd or the 24th. So it's the 30th. The 30th. That's close.
And then with recovery, you see mostly what we've been working on, thanks to Willow's presentation. Codifying the definition of OYAT, to put a youth consideration on it. And then coming up with our data metrics for it. And soon we'll dive into peer services, everything peer services, probably focus on practice settings. Anything that's developed. Great. All right, so next we can do public comment. Do we have anybody from the public who signed up for public comment?
Nobody is signed up.
Anybody want to say anything?
Yeah, I'd just like to make a brief comment if I could.
Yeah, go ahead.
Hey everyone, I'm Doug Riggs. I'm the executive director of the Alliance for Kids, a group that was founded in 2005. And we have 8 members on our board, including groups like Janus Youth Programs, New Avenues for Youth, Looking Glass, JBRJ, et cetera. And we care, our monikers that we care for kids 24/7. And so it's been interesting. We've been going through this whole discussion on SUD treatment for the last 3 or 4 years. Over 50% of the kids who come into our programs are facing some level of addiction. And yet we have very few resources available to homeless youth providers. So I'm really fascinated by the conversations in the last presentation about school-based treatment, which is great and fully support it, 100% behind it. Doesn't really reach our kids, most of whom are disengaged from schools. And then recovery centers, I also think is a fantastic idea. But again, I don't foresee any of the youth who are in our programs voluntarily taking advantage of that. So I'd love to sit down with the commission staff over the next few weeks, and also the opioid settlement work group, and kind of talk about how we might be able to address this shortfall. It's something that we had in a legislative bill, House Bill 3079 in 2025, that did not advance. We plan to bring it back in 2027. But in the meantime, love to chat more with you. And I've been asked by my board to see if there's a way to kind of formally work with the ADPC on these issues going forward. So just a public comment. Again, I think it's fantastic, the 2 proposals that you have on the table. Well worth it, but I'd like to figure out how to fill the gaps in our very high level, high acuity system.
Yeah, thank you so much for that, Doug, and for the work you guys are doing. If I can make a recommendation, to have you email Annalise, our director, she's probably happy to set up the time with you to talk about some of your options.
Will do. Thanks.
Okay, thank you so much. Anyone else for public comment? Okay, for those of you who were not here with us in person, we're gonna have leftovers. And Anthony, take a photo. We wish we could have saw you. Frankie, again, thank you so much. We hope to see you back, and feel free to reach out anytime. Caroline, you're not leaving yet.
Yeah.
So expect to see you next meeting in July, and appreciate all your help. And with that, I'll close.
And Tony.
Oh, but.
And Tony.
Oh, well, I'm still on the hook. So.
Let me do last
Oh, okay,
real
okay.
quick. So next month in July, we're going to do the comprehensive plan Q2 update. August, we are taking off, just as a reminder. September, we'll talk about the financial assessment. And then we have some kind of things and partners for October. But we'd be remiss if we did not again recognize that this is Tony's last gaveling out, which I think I'm accepting, but I still is here to talk to me every day. And then, even after.
Whatever you need.
Even after Amelia and Annalise cried. But really, Tony, so really like Amelia.
No, it's Lynn.
That's not really her. It's like 70s. But seriously, Tony, I mean, I think I am, I speak for everyone when I say thank you for everything that we've done. We're not off the hook. That's why you don't have your plant today. You did get an onesie for the new kid, but, we're grateful beyond words. Yeah. Definitely. Yeah, I don't know.
Okay, gavel out.
Yeah. All right.